Good afternoon, everyone. I appreciate you all taking the time to join our second iteration of the working group. We're going to give folks just about another minute to join and we'll go ahead and get started. So thank you so much. All right, so we're going to go ahead and get started. I know folks will be joining us as time goes, but want to thank you all for joining us on this afternoon. Feels like the middle of the night with how dark it is up here, but really excited to officially call this meeting to order. Again, this is our second meeting of our Medicaid Benefits Working Group. For those who haven't met, my name is Ann Jensen. I am the Innovation Officer here at Nevada Medicaid, or the Division of Healthcare Financing and Policy. And I'm really thrilled to share a little bit more about our work and get your input on our transformation effort today. So with that, we'll go ahead and get started. As always, we'll begin with a roll call of our working group representatives. We'll then spend the majority of our time together today on a population health data summary. So what that looks like is a review of our available data on the behavioral landscape in Nevada and Nevada Medicaid in particular, and really look forward to your input on what we're seeing in the data and how we're designing our effort to really address the needs of our community. We'll touch on how we're going to rebrand our work and come up with a name for this transformation that really resonates with the community. And then we'll be wrapping up by 5:30 so you can get on with your evening. So as a reminder, this is the Nevada Medicaid team that is supporting this work. Want to thank everyone on this slide and the many, many others behind the scenes that are supporting this effort. Please know that this is an effort of tens of folks here at Nevada Medicaid supporting this on a daily basis. So I am communicating a lot of information, but really appreciative of the full team that's been helping with this work. So with that, I will move towards our roll call. So I'm going to go through the list. Would love for our working group representatives to come off mute or in the chat, let us know that you're here. If you didn't get a chance to introduce yourself at the previous kickoff meeting, would love for you to share a little bit more about your background and your kind of what brought you to this group. So we'll start with Matt. Are you here today? Matt Lehman. Okay, not hearing you yet, but we'll come back. Leah Skinner.
Hi, yes, I'm here today.
Wonderful. Thanks, Leah. Good to see you. Lanisha, are you here?
Did you say Annalicia?
Oh, I said Lanisha, but Annalicia, I'm glad you're here as well. You're just farther down the slide. So welcome, Annalicia. It's great to have you. Lanisha, I know would join us over phone last time. So if she's having trouble getting off mute, feel free to chime in the chat, but we'll continue to move forward. JD.
I am here. I'm here.
Wonderful. Thank you, JD. Good to see you. Devin Daniels, are you here? Okay. Hopeful Devin will join us shortly. Annalicia, I'm glad you're here. Welcome. We're glad you're part of this group. And Luke. Are you here? Okay, we'll come back. Let's move to some of our providers.
Yes.
So, oh, sorry, Luke, are you here?
Yes, sorry, my computer's just a little slow.
No worries, no worries. I know how that goes. Glad to have you. Alrighty, Alana.
Here.
Wonderful, glad to have you. And Dave let me know that he is unfortunately on a plane, so is unable to join, but I know we do have a number of folks from Eagle Quest that are here representing today. Dr. McGrew.
I'm here.
Wonderful, thank you. Dr. Freeman.
I'm here.
Great, glad to have you. Dr. Cooper is presenting on rounds right now, so she will be joining us next month. How about Glenda?
I'm here.
Wonderful. Thank you, Glenda. Natalie?
Here.
Great. Thank you. And Stephanie?
I'm here.
Okay, glad to have you, Stephanie. Janelle?
I'm here. Thank you.
Wonderful. And I'm sorry, I just missed. Stephanie, do you want to introduce yourself to the group? I believe that you had a conflict during our last meeting, so I want to make sure folks get a chance to meet you.
Yes, thank you. My name is Stephanie Brown. I'm the Director of Business Development for Reno Behavioral Healthcare Hospital, and I'm happy to be part of this group.
Great. Glad to have you. Alrighty. Angie, are you here? I think she may be joining us shortly. How about Nikki? Hopefully Nikki will be joining us. Gwyneth? Gwyneth Smith? She let me know that I think she's going to be coming a few minutes late from her special court today. So we'll hope that she can join us shortly. Jessica, I believe you're on today.
I am here.
Wonderful. Thank you. Mayambi.
I am here.
Great. Thank you. And Shayla.
I am present.
Wonderful. Thanks, Shayla. Do you want to introduce yourself to the group as well?
Sure. I am Shayla Holmes. I'm the Director of Lyon County Human Services, where we serve the lifespan. So I do have a Children's Services Division that does prevention and early intervention, as well as differential response for several counties. We also recently, as an organization, became an outpatient provider and have started a behavioral health division as well. So I'm excited to be a part of this working group and here to represent rural counties.
Great. Thank you. We're thrilled to have you part of this. Thank you, Shayla. And last but not least, our community partner representatives. Bree, are you here? How about Karen?
Good afternoon. I am present.
Wonderful. Thank you, Karen. And Robin. Alrighty. How about Jonathan?
Present, thank you.
Thanks, Jonathan. And Santosha. I think she's on the call. Are you on the phone, I believe? Santosha, are you here? Saw her in the chat. So I'm also getting notes that apparently there was maybe a different link that was posted on a different page on Dot Control. So there are a number of folks that will be joining us from another link. So I do apologize for any confusion. I want to thank Monica from my team who's working with those folks to come on over. So we'll come back to our roll call. We do have quorum here to move forward, but we'll come back and make sure that anyone who's joining us late should have a chance to introduce themselves as well. So thank you for that.
And real quick, Matt put in the chat that he is here.
Wonderful. Thank you, Matt. Great. Alrighty. So as a reminder, the purpose of this working group, this slide is from our last month as well. So it's to offer advice and expert opinions and suggestions to our team regarding the transformation project. So we know that our representatives represent a range of experiences, lived experience as a family member or member who's received these services, as well as a range of providers and community members and advocates. So we really thank you for your time and the investment that you're making in this work. Please know that we're using this input, we are documenting this and communicating. We meet at least 3 or 4 times a week on this project and are using this input in each of those. So I want to thank you again for your time and wanted to make sure that those who missed our first meeting had a chance to see this summary. And as a reminder, this meeting is subject to open meeting law, so we really appreciate all members of the public that are here as well. The goal is to make this forum as discussion-based as possible. So I invite any that are able to join us on camera and really welcome you to raise your hand. Notably, the discussion section will be with our working group representatives. There will be a chance for public comment after each agenda section. So we will have that as a dedicated slide. So we welcome members of the public to contribute at that time. So with that, we're going to move into our agenda today. I'm really excited to share a little bit of data we have here at Medicaid, both at a national level, a state level, and within our Medicaid data sources as well. Some of this may be familiar to those that have been here a lot longer than I have, but I found this to be a really helpful summary of really where we are at as a state and where we need to go with this transformation. So I'd like to start with some national data here. There is a nonprofit called Mental Health America that publishes an annual ranking of states based on outcomes and access to care. And you'll see here that Nevada is ranked 51st out of 50 states in the District of Columbia. And that has been the case for 7 years, the past 7 years in a row. So as we know, we have significant improvements to be made. You'll see a couple aspects of the ranking, components of where that goes. The slides will be posted publicly as well if you'd like to take a look at that full report, but a sobering place to ground ourselves as we go a bit deeper. So this shows kind of a range of where some of those outcomes are stemming from. So you'll see 1 in 6 children across our state have a diagnosed mental health condition. And that ranges, high school students are reporting prolonged sadness or hopelessness, as well as suicidal ideation, well above national averages. And 1 in 7 children in our state are diagnosed with a substance use disorder. This, importantly, is statewide Nevada data. We're going to talk about what that means from a Medicaid context. So just to level set here, Medicaid covers 1 in 2 children in our state. Clark County has the highest proportion here of 3 in 5 youth in Clark County are covered by Medicaid, 2 in 5 in Washoe, and 1 in 2 children in our rural counties. Notably, 78% of children covered by Medicaid identify as Black, Indigenous, or other categories of people of color. We'll use the term BIPOC throughout this presentation. Notably, 88% of Black children in our state are enrolled in Medicaid. So there are very significant health equity implications for this work that we're undertaking. So with that context on who we're serving with Nevada Medicaid, I think it's important to turn to what do the behavioral health outcomes look like within that population. So you'll see here it's quite similar to that slide I shared earlier on what that prevalence looks like across the state. So 1 in 6 children statewide and within Nevada Medicaid have a diagnosed behavioral health condition. 80% of those children live in Clark County, which is roughly proportional to our population. 74% of children with a behavioral health diagnosis identify as BIPOC, as part of a BIPOC population. So with that kind of contextual data, I'd like to dive into a few specific areas. And this is where I'm really excited to pause. I will not be talking at you this full hour. We're going to pause after each of these and have some discussion as it relates to 2 aspects of care in our behavioral health continuum. So one is on our residential and inpatient treatment side, and the other is on our outpatient and community treatment. So with all these terms, I know all of us are coming to this work with a lot of different experience. I think it's helpful just to start with some level setting and some definitions. So inpatient services here, when we use that term, what we mean is short-term intensive care in a hospital setting for children with acute needs. So this is clinically appropriate for acute mental health treatment that requires 24/7 monitoring. It is not intended to be a long-term management of chronic conditions outside of crisis periods. Our residential treatment centers, or residential treatment as a care opportunity, really provides longer term care than that inpatient service. This is housed in a live-in facility where children receive therapy, education, and support. So this is really intended to be the highest level of acuity outside of a hospital setting for conditions that are manageable through not manageable through regular outpatient services or community support. So that's quick context. Excuse me? Maybe getting some echo there. I'll pause for questions in just 1 second. I just want to share a couple items about Nevada data, and then I look forward to the group's feedback here. So a few details specific to those types of care in Nevada. On the inpatient front, you'll see here that children enrolled in Nevada Medicaid have a 51% higher risk of an inpatient stay associated with a behavioral health diagnosis compared to the national average. So that bar at the top is the United States average of how many inpatient visits associated with behavioral health conditions there are. In Nevada, you'll see that bar is much longer. There's about 584 visits per 100,000 children. On the residential side, Those stays also outpace national averages, but it's a little bit harder to get that direct apples to apples comparison. And so you'll see here a summary of some of our residential treatment facility data. You'll see that nearly 20% of children in Nevada, children enrolled in Nevada Medicaid, were placed in an RTC out of state, so not in the state of Nevada. And nearly 1 in 3 of those children stayed in a residential treatment facility for over a year. So the average length of stay is between 9 and 12 months. Notably, Medicaid spending really skews heavily on this high acuity settings. So 80% of Medicaid spending for behavioral health services is in residential or inpatient services, which equates to nearly $38 million of Medicaid funds spent on residential treatment alone. So I know many folks here have direct experience with these programs, and we all know that the outcomes of these treatments really vary. These levels of care have a very important role in the continuum for behavioral health, as they allow for increased safety and stability and access to intensive therapy. However, there are negative outcomes associated with longer term uses of these services. So you'll see data here related to high rates of symptom relapse, and the benefits kind of plateauing as those stays continue over time. So wanted to paint the picture here to show kind of what that use looks like. And then from here, I'd love to really spend some time to reflect with our working group representative. So would love to hear, you're welcome to come off mute and answer either of these questions. The first being, what successes and barriers have you experienced or observed here in Nevada when accessing or providing inpatient or residential behavioral health services? And secondly, kind of focused on, as we look forward, what can we do? We are currently planning to adjust how we pay for these services, specifically for residential treatment, to really consider how we can incentivize providers to serve children with complex needs, younger children, and serving youth in a really high quality way. And so we'd love to hear, we'll share more about what that looks like in future meetings, but would love to hear, what else should we have on the table? What other solutions should we consider when addressing these barriers to high quality residential treatment in particular? So I'll pause there. Thank you for letting me share. I know there's a lot of information. Happy to answer any questions and welcome feedback from our working group representatives here.
Sorry, Anne, this is Dr. Freeman. You might have said this, but are we going to do a slide like on outpatient too after this?
Yes,
Okay,
good
sorry.
question. After this will be outpatient and community-based services. So we're starting on the inpatient and residential side.
Sounds good.
So Shar Frost has a question in the chat. She's asking, when you talk about early intervention, are you including early childhood services?
Thank you, Shar. I appreciate that question. I'm sorry that I may have missed which slide that was speaking to. So do you want to come off mute here and let me know which slide that was in reference to? Was it this slide in the continuum?
Yeah. Hi, this is Shar Frost for the record. Yeah, because it says early identification and intervention, and I was just, one of the things that concerns me is that in Nevada we often miss early childhood, and which is a great time to get in and kind of prevent some of the longer term outcomes that we're trying to avoid.
Yeah, I appreciate that. I think we need to call that out more explicitly. I think we view early childhood as an important part of that early identification and intervention bucket, but we're also looking at how can we ensure that our services support youth at all ages throughout each aspect of the continuum. So I think we can do some more to really clarify that population in all aspects. So thank you for calling that out. I appreciate it. Yeah, Natalie?
Hi, thanks. Natalie Sanchez, Health Psychology Associates for the record. So on the slide that we had where you had the questions, so the 1 and 2 questions, I was thinking about number 2, and we are a Health Psychology Associates does do outpatient mental health. And one thing I would say from our end that would be really helpful from working with folks on the inpatient side, if there was more of a case management aspect in terms of when somebody is being discharged from those services, how are we getting that information? How can we make that process a little more streamlined and hopefully make those stays a little bit shorter if we can, because they already do have maybe some outpatient mental health support.
Thank you. Yeah, I appreciate that. I think transitions of care are so crucial between each one of these steps in the continuum. And so we're trying to think through in our revised residential treatment policy, actually, we do have some language about what that care transition from a residential treatment facility needs to look like and what kind of support the youth and family are going to receive beyond just a single document of a phone number. So we're thinking about that in the current policy, but I appreciate you calling that out because I think there's more we should do between every level of care and trying to connect that. So look forward to your feedback as we kind of discuss different benefits here to think about how we can embed that in each one. So I appreciate that. I believe Alana was next.
Yeah, hi. So I will address both question 1 and 2. So being a CCBHC, we definitely have case management that tries to coordinate if somebody is inpatient or residential. Unfortunately, it's working with other facilities. We're just not on the same page. So our case managers have a huge load and would love to contact hospitals and residential facilities and get that plan started way before they're ever discharged. And we hit huge barriers trying to get information. We're constantly told we can't talk to you. So that's been a big roadblock. So maybe educating on the different agencies and what exactly would need to be shared between each one, and having a very general ROI, which would allow communication. As far as success and barriers, I think the biggest barrier is we don't have enough facilities, especially inpatient and residential, for children in our area. You cannot find anything. You really can't unless you go out of state. It's very, very hard. So I think maybe doing something with reimbursement where facilities actually want to stay in the area and we can have quality providers.
Absolutely. No, I appreciate that. I'm excited. We have a public meeting in just about a week on our residential treatment facility rates and some changes there. So I will make sure that that information is shared on our behavioral health listserv. I believe it is already gone out already, but that'll be a good chance to get input on our attempts to address those very concerns. And Alana, I appreciate also hearing your feedback on the transitions of care piece, very similar to Natalie there, and I think a lot more we should discuss. So I'll make sure we note that and continue that conversation. Rose?
Hi guys, sorry for the not camera. I'm having some tech issues, but I work with the Nevada Department of Education on school-based mental health grants, and we recently put out a few trainings that I did where the reimbursement procedure recently changed, I believe with AB 51, where the state would reimburse hospitals and treatment centers for the education provided while kiddos are residential. They can now go through the districts instead of the state. And in these trainings, we came across a lot of barriers and struggles that we're seeing that kind of impact the whole system. One, kind of like Alana was talking about, is that transition protocol. We've been advocating for the Birch protocol, which is out of UMass, to transition back into school once they're getting out of residential treatment, if they are not going into some type of intensive outpatient treatment. And a lot of the barriers that we're hearing as treatment centers don't know who to contact, and the schools don't know who to contact at the treatment centers. There's struggles about transferring records back and forth. The reentry plans and the transition plans, sometimes there's no time to do it before the kiddo is discharged. Sometimes kids are discharged rather suddenly, and there is no time to plan. So I don't know of a solution. We're trying to increase communication between school districts and treatment centers, but we only have 4 currently that are reimbursable. There's very few options in this state, but I'm actively in contact with other treatment centers who want to get reimbursed through that track. And it is for those educational services, but it is something that they can work towards as well. So if you guys want to spread that information, that that's an option to get reimbursement, that's something that treatment centers have the option of doing as long as kiddos are there for 7 days or getting education services for 7 days. But I just kind of want to put out that we're seeing some of those same struggles and barriers on our end as well.
Thank you, Rose. I appreciate that. And our team that's working on that residential treatment policy on our end is on the call. So I'm excited for them to take back your feedback, especially on that model from UMass as well, and think about how we can utilize that in our work as well. So thank you for that.
Awesome. Yeah, thank you guys.
We'll keep going through our list. Leah?
Hi.
So as a parent, some of the barriers that we're coming across, like I know with case management, I do agree that that should be addressed as soon as possible because it does take a long time to put those referrals together. It takes a long time to get with those facilities to understand if they have the specialty treatments that some of these kids need. But also, I want it to be kept in mind that as a parent, you're still in crisis with your kid, right? So right when your kid goes into a facility, whether it's acute care or long-term care, the parent's trying to go through and figure out what steps need to be taken. So I think in all of the things that I've heard of the people that were talking before me, I hear you, I validate you. And as a parent, we want to help you, or at least I do. And with that, I think it's the parent's education too. So educating and being patient with the parent. I've been in situations where it feels like they're putting their job on me when I'm trying to do my job, be a parent, get my child through this crisis, get her through acute or residential. And it's a lot. So the more education that we can get, the better. And I think also it would be really great to have it black and white of what the expectation of discharge is, because there's so many times where I had to battle of, well, no, we don't have a plan, a safe discharge plan. I am not able to accommodate what needs to happen as a parent. So having those appointments lined up and having those doctors available and having that plan, I think that education needs to be spread to the parent of what their rights are, what they need to do, what's expected of them. Because even though our brain's not there right when you call, if it's written down, we will get to it, or at least the parents that are really trying will. In that case, if there are parents that aren't trying, I don't know if there's another sector that we can add on top of case management that would be like a counselor working together. So where the case manager would strictly work on referrals and collecting, where you would have another position that would, hey, what questions do you have? How do we support you? And, make sure that your voice is being heard. I don't want to sound like I'm rambling, but these are some of the barriers, and experiences that I've had, which I feel are important to state.
It's absolutely important. Thank you for sharing that. And I think really affirms to hear it from both a parent and a provider perspective, right? We're all on the same team to try to smooth that transition. And I think there's a lot of work we need to do to make that a meaningful and collaborative process. So thank you, Leah, for sharing. I do appreciate that. Karen?
Hi, and thank you so much, Leah. At Nevada PEP, we talk with families all the time who are experiencing much of what Leah has experienced. I've got three main points. One is it's difficult, and Leah touched on it, in some cases to get in to a facility because of the child's disability or mental health issue. Typically, if there are a number of behaviors. And so then those children either don't get in or go out of state. So we have to do something. I know other states have had a no reject, no eject policy. And, I know that an absolute of that policy probably isn't workable, but the concept should be looked at. Number two is education. While youth is in a facility, hardly ever happens in a manner that they can maintain their credits for the school that they go back to. And so we help a lot of families whose children did not get credits and can't move on or graduate because they were hospitalized. So that is a big issue, and that is also part of the discharge. And Rose, talking about the model, just so you know, Rose, we held focus groups with parents across the state on that model, and really like the fact that there's intention behind planning for the youth to go back into school. And then, of course, discharge. So many families call us who have been discharged and don't know what to do next. There is no discharge plan. There's no warm handoff. It's really a shame because they really don't have the information or the support they need to come and pick up their youth. And so discharge is also key. Thank you.
Thank you, Karen. All three very important points, and I appreciate you raising. I'll also ask our team that's working on the treatment facility policy to drop the link to that conversation in the chat. I think it'll be really very relevant feedback here that we will take to that conversation. But if you're interested in even going deeper on residential treatment facilities and what our policy looks like, we definitely encourage you to join that conversation as well. So thank you for that. Dr. McGrew?
I will try not to rehash too much. I agree with everything that has been said thus far. So I'll just kind of add to it. I think the coordination of care issue is huge, both with going in and coming back out. And solution wise, we might need to look at how to make that whole process reimbursable to providers in order to incentivize doing that. I know that for me personally, as a behavior analyst, I have no codes for that. I spend many, many hours coordinating care that I can't bill for. And I do it because it needs to happen, but it certainly is easier when there's a way to get reimbursed for that service. It's easier to prioritize that as a provider. And I think that we need to look at what we're doing around reimbursing the services that need to be happening. I think also I'd like to mention that there are diagnostic barriers in a lot of cases. So I've frequently seen individuals rejected because of different diagnoses that they have. But similarly, I can't offer my services. I can't tell you the number of calls I've gotten from Texas Neuro where they want to discharge and they want like intensive behavioral services. And because there's not a diagnosis of autism attached to it, I have to say, I'm sorry, like nobody's going to pay for that. And oftentimes there, are doctors that have said like, this is, the service that we're recommending. So kind of diagnostic standards are trumping clinical judgment in those cases and are often a barrier to accessing those services when an individual might need, a high number of hours outpatient as a transition from being inpatient. So I just wanted to put that out there.
Thank you. I appreciate that, Dr. McGrew. And it's true, the reimbursement piece, I think, is a really an important lever for us to consider here. It is on our list as we're going through the transformation, and I appreciate the focus and push on that, something that our team will take back. And the diagnostic piece, we could spend, I know, many hours in conversation on that one, and there are many internal conversations on that as well. So I think that'll be an important topic for us to cover at a future working group as well. So thank you for raising that. I appreciate it. Janelle?
I think I agree with everything that everybody has said, and so I won't, keep going on that. But some of the barriers we've seen at the hospital have been just the only opportunity for us to get a child treatment is out of state. And so that's the only thing that's open. But then how do you reconnect them? And as an acute care hospital, how do we reconnect them with their family? How do we set them up for success? And again, a lot of these kids, we had one child just recently that the only option was in Missouri. Well, Missouri, that family's not going to be able to go there with them, especially in the financial situation that they were in. And that's just not setting up a child for success. And why we as the state of Nevada aren't doing more for our kids in our own state is what bothers me. From another side of it, a lot of what we see coming into our hospital is parents who are exhausted, who are just at their wits' end, and they need a night, they need 2 nights, they need some type of respite care, and that's not a billable service for us either. And so as we do take these children in, and we give them a safe place to be, and we give the parents the opportunity to go home for the night and get a night off or get a moment. But that really puts us in a really hard financial position as well. And then sometimes we've seen kids that the parents realize we can't come back and get them. We're not the safest place for them to be, or it's not safe with our other children at home. And so then this child ends up staying in an acute care hospital for 30, 60 days without us really being able to provide that level of care. It's a pediatric unit. You know, it's not set up for that behavioral health care. We have decided, and permits are in place now, that we are putting in an inpatient unit. So we have a 10-bed inpatient unit and also a crisis stabilization unit that will be opening in Carson City by June. Or our hope is by June, hopefully we'll have it done, but still that's just not going to be enough. We know when we opened our Mallory Crisis Center, that wasn't enough. And we did that for the last 8 years of having Mallory Crisis with no reimbursement from the state. That was completely done at, we paid for it ourselves, and we know that that was a need for the community. So I think that's where we have to go. We have to figure out how do we balance that quicker? How do we get reimbursement quicker? And then how do we find things locally so that we're not separating these kids from their parents?
Absolutely. I appreciate you sharing that and all the work you and your team are doing to really care for youth and families in this exact situation. Fully agree. I'm really excited that both planned and emergency respite is a benefit that we're developing as part of this transformation. And I know it also can't come soon enough. So thank you for sharing and really reinforcing why that's going to be so crucial. I appreciate it. Matt?
Hi, so I have, again, like everybody else, these are all repeating the same kinds of concerns. The other one, as my fellow behavior analysts and parents can tell you, is that frequently we run into barriers on the residential side, where right now the coding restrictions as enforced will often end up being for some of the kids who, either as part of the step down transition to be able to get out of a residential setting, or even just to be able to be successful in an in-state residential type of placement, especially for a lot of our diversionary court kids who also have an autism diagnosis or an FAS diagnosis, etc. Generally speaking, that's not billable, or the billing as Medicaid has it conflicts, even though we can do it with commercial insurance. And so that creates a whole bunch of places where we're not able to get in there and do the things that would provide that better level of support and probably ultimately reduce the cost. And it's a concern to me always when commercial insurance and even managed care options of Medicaid are providing better services or better access to care than what fee-for-service Medicaid is willing to allow or authorize when they put in substantially significant limitations, even up to and including the whole, and again, the behavioral analysts and parents who have kids who are, like myself, who are receiving ABA therapy, the rolling 7 days to do 1 hour of parent training with a nonsensical explanation of why that limit is there, that is not present for any other funding source, creates, again, that push into some of the clients ending up in residential care and needing higher, more intensive services for longer because of barriers that are discriminatory, essentially, on the Medicaid side because they aren't present on the commercial side.
Yeah, thank you, Matt. I appreciate that. And that is actually a topic that our team that's looking at the residential treatment policy has been discussing. And I think that will likely be something of discussion at that policy workshop next week. So I appreciate you raising those discrepancies is something that our team has noted. So we will look forward to more conversation on that. But I appreciate really how that your tie to how that leads to longer stays, which we know are not associated with those outcomes and appropriate transitions that we're looking for. So thank you for raising that. I appreciate it. Dr. Freeman?
Thank you. I just wanted to quickly comment on barriers for the families that we serve at the Boys and Girls Clubs. Barriers to mostly what we've experienced in our role is helping families access IOP and PHP. And a lot of times transportation is a barrier if the youth wants to get there in person. That's been problematic for the families that we serve. And then we've had a couple of requests. Could we like supervise an online PHP IOP because the parent has to be at work during the times that the youth is supposed to be in the program, and we just, like, as much as we want to do that, we don't have the resources to do that safely, so we've had to say no. So I just, for families who have significant resource limitations or multiple system needs, just some like really basic barriers like transportation can prevent the youth from being able to access the program.
Thank you for raising those, Dr. Freeman. Agree that those are some of the really challenging, but hopefully more addressable barriers that we need to really focus on through this transformation, specifically on that transportation side. That's what comes to mind for me first. And I also appreciate you raising PHP and IOP to avoid our alphabet soup of acronyms. That's partial hospitalization programs and intensive outpatient programs. I'll note that those are not called out in this data here. This is kind of a summary on two aspects of a high acuity, and the middle section we don't have data on today to really present, but I appreciate you mentioning those. Those will get a lot of time and attention and discussion in future working groups as well. So thank you for raising that. And I think we'll conclude with this section with Jessica.
Hi, thank you. I just, in follow-up of everything that has been said, especially regarding like the safe transitions for family members, I did want to just note that we have seen an incredible increase of families from a human services agency, from a CPS perspective, where we're getting reports both from families and also from providers who are basically, saying like these families are not willing to come and pick up their kids, and families are calling also and saying like, we're not trying to neglect our kids, we're not trying to not pick them up, but we don't safely know how. We don't feel like we have a good safety plan. We don't feel like we can keep the rest of our, family youth, ourselves safe. We don't have a provider. We don't know where they're going to go to therapy when they leave. Sometimes it's, we're from the family's perspective, and I know, in digging in and working really closely with our hospitals around here, this is not always, it's not always 100% either way. All or nothing, but some families feel like they're given, very little information and very little transition time, to the point where they feel like sometimes their only option is to let, their children come into the child welfare system, which is definitely not the best case for anybody, especially from the perspective of then the services aren't any better because their kids are in child welfare. And so if we can really work on all the things that have already been said, but I just thought it would be important for me to mention that because of all of the things that have already come up, that we really are seeing an influx of kids coming into care because their parents don't think that they can meet their behavioral and mental health needs, or don't feel like they have the appropriate resources when being discharged from higher levels of care and acute facilities.
Absolutely. I appreciate that, Jessica. And I agree that that is fundamental that is one of the most core problems we're trying to solve with this transformation, right? No family should ever have to give up custody of their child to get them access to the care. And I appreciate what you're sharing, which is you, from that perspective, are doing all you can to provide that care. And it's really challenging when it looks very similar on both sides of that coin. So thank you for sharing that. So in the interest of time, we're going to move forward to our outpatient and community-based services section. I appreciate all the engagement, and there's so much that we're going to continue to get into here. So if there's other things to add, we welcome those, both in the chat and in future meetings as well. So as before, starting with a quick definition of what do we mean when we say outpatient and community-based services, really looking at those that are provided within our community and other behavioral health clinics and locations that do not require an overnight stay, really meant for ongoing support to care transitions and mild to moderate needs that don't require 24/7 support here. So As many have touched on here, there's a number of positive outcomes linked to these treatments when used in the right place at the right time, including reduced hospitalization, stronger focus on family-centered care, and higher cost effectiveness as well. The challenge, of course, as we all know, is that access to these providers in Nevada is much lower than national averages. So again, that same Mental Health in America report, Nevada ranks 45th out of 51 states and DC for access to behavioral health care. And every single one of our 400,000 children in Nevada covered by Medicaid live in an area with a shortage of behavioral health providers. Every county in the state is considered an area of behavioral health provider shortage. I know that's not new news to anyone on this call. I did find this data from our team, our analytics team, to be really helpful. It's a map. I know the numbers are a little small, but it's a map of where our current providers are enrolled in Medicaid by county. What this averages out to is one outpatient behavioral health provider per 100 Medicaid recipients. And I'll note that, as we all know, based on the geography of our state, just having a provider in your county does not mean that it's an accessible provider, of course, right? Many barriers to access, ranging from transportation and scheduling and availability and all of that. So again, reflection on this side, on the outpatient community-based services side, successes and barriers, welcome feedback there. We've talked about in our last meeting some of those array of benefits that we're looking to develop, things including peer support for families and youth, planned and emergency respite care, wraparound facilitation, and other intensive in-home supports. And wanted to really open it up, since it's been a month since we last shared that list. Curious if there's anything else that this group would like to share as things that we should consider to really increase the availability and robustness of these services. So I'll start with Dr. Freeman.
I'm not sure if this is exactly what you're asking about, but it's really relevant for us. We do a significant amount of preventative services, like mental wellness, social, emotional learning, and by giving youth that foundation, we're increasing the likelihood or decreasing the likelihood of them getting on a trajectory to needing more higher intensity level services. And I'm not aware of any way for us to bill for that time. And so right now it's a gap in my budget, because we don't, like someone else who mentioned a lot of time doing care coordination. We do as well. Some of that time is billable as case management, and some of it's not, but the benefit to the family and to the system as a whole, there's like return on the investment of that time on our part to the system. And so I think that's a gap that potentially could be addressed.
Thank you for that. Yes, we will note that and see what we can do on our side. So I appreciate that. Natalie?
Hi, thank you. So I am lucky enough to belong to several different consultation groups with a bunch of different providers in Washoe County. And so I went back to them after our last meeting and said, I have a little bit of a poll because I'm the only one out of a group of 35 that takes Medicaid. So I wanted to know, why is that? What are some of the barriers? And so some of the big things that folks were indicating were that, the big one, reimbursement, that it is not cost effective for them as an agency or as a private practice clinician to take Medicaid. The second thing is, we talked about it last time, really the administrative costs. And then one of the the third thing that everyone kind of spoke to is that it's so difficult to take Medicaid. And in particular, if you're taking an MCO, that you don't have a representative or somebody who you can talk to and someone who can follow through on something. So oftentimes a really challenging or difficult case might get lost in the shuffle. And also you're not getting reimbursed for that time. So again, it kind of goes in this massive circle. And, I think if there was a way to make this more attractive for folks, because there are a lot of providers out there and there's a lot of really great providers who I think are doing some great things for kids and families, but given these barriers aren't willing to take Medicaid, and then hearing the movement to the MCO are really saying, no thanks, I think I might drop, and I won't consider it at this point. So
Thank you, Natalie. I appreciate that. And I'll share and kind of how we're organizing our transformation work internally. We have, of course, folks working on our delivery system and our benefits, and there's a whole body of work we have related to our provider experience, enrollment, increasing access, and decreasing administrative burden. So I appreciate you sharing those, and I look forward to getting that full list from you and the rest of those providers as we really dig into the weeds of that work. So thank you. Gwyneth?
Good evening, everybody. This is Gwyneth from Clark County. I just wanted to kind of second what I have already heard in the discussion with respect to the importance of respite care services. And I come at it from the perspective of the DA, who's assigned to both dependency matters as well as delinquency matters. And there was discussion of the kind of increasing influx we see of families in the community who come into those systems, not because they're really meeting the definition of neglect, but because they can't kind of safely maintain their children in their home. And I just think having robust, accessible respite services is so important for these families, either families of origin who want to maintain their child, or I can think of several recent cases where we were very close to adoptions proceeding for a child, and those adoptions are no longer occurring because that prospective resource said, in the absence of really having a solid understanding of respite care for this child with extremely high level need, I'm not comfortable proceeding. And that's just really a tragic outcome. So I view respite services, as Karen has mentioned, both emergency but also planned, as a game changer if it can be effectuated. And I say that knowing it's not an easy system to establish or fund or set up, but those services are very, very important.
Absolutely. It will not be easy, but it's critical, and we're really eager to move quickly and do it the right way. So I look forward to your feedback throughout that process, as well as the rest of this group's here. So thank you for that. And Dr. McGrew.
Yes, so I would definitely second on respite care. That's a critical need throughout the state. But I think also getting creative about kind of family and caregiver education. There are some really solid systems in and around kind of crisis management and de-escalation that, if they could be rolled out in a more systematic way, would also give families the skills to cope and to kind of make it through, from crisis to crisis without seeing kind of maximum, escalation and crisis in what they're doing. And that overall would lower their level of stress. So I know that when I've done this sort of training with parents, just the confidence that it builds and the kind of breathing room it gives them because they have a skill set in that area can be important. So we're threatened with a huge provider shortage in this state. Like, so much of it is resource constraints, but pushing out those informations and skills in a structured way can also be of benefit.
I appreciate that. That's a really important point. How can we think as creatively as possible about addressing this provider shortage? And that could be a really important way to do it. So let me make sure we take that back with our team and see kind of what other national best practices look like across the country as well. So thank you for that. So we'll continue to move forward here in the interest of time, and definitely welcome others to chime in the chat. I think I really appreciate what each person in this group has shared, including personal experiences with their family or loved ones. But I do always want to center this truly on those that we're serving. And this quote here is from a parent of a 14-year-old in residential treatment in Nevada, who's covered by Medicaid, and really shared how challenging that experience was for them, and how crucial it was to bring those services back in state and really to keep him at home and in his community wherever possible. So I know reflected by many on this call, but I think it's an important thing for us to really continue to focus on as we move forward through this work. So in closing here, I know we have just a few moments left, and I do want to save time for public comment. So I'll conclude. This is a slide that you have seen before. This is really how we're viewing the rebalancing from current state to future state. Each part of that continuum being crucial, but trying to really right-size the availability and access of benefits across the full array. So I look forward to sharing more about one of those benefits in our January meeting here. So I'll teaser for what I'm going to share in just one second. I do want to call out, these are a few questions that we did not get a chance to cover today, but I think are really crucial. And we will revisit this at an upcoming meeting. In particular, question 3, thinking about how do we measure the success of our transformation, right? We've seen data today that really measures where our system is failing. And those things are not surprising to any one of us on the call. But I think what's really crucial is to think about, as we build something new, what are the metrics that we're using to tie to success and measure whether what we're developing is actually working for our youth and for our families. So I'd like to leave you all with that question, food for thought. Feel free to shoot me and our children's BH email a message if you have any initial ideas, but we will come back to that for a broader discussion. I think it's a really important part, right? There's one thing to look at data and there's another thing to really use it to measure our success. And I don't want that piece to get lost. But I want to thank you all for your feedback and contributions today. It's really helpful and reassuring to hear the range of perspectives that we're bringing. And I'm really heartened by the folks that we have to do this hard work ahead. So speaking of what's ahead, I want to call out our next meeting. So our next working group will be January 9th from 4:30 to 5:30 p.m. As I mentioned, we're really going to be diving deep on those home and community-based benefits. First, we're going to talk about what is a Medicaid benefit? What does it mean to develop something as a Medicaid covered benefit and kind of open up the hood to show what that process looks like internally. And I'm really excited that we'll get to focus on family peer support as the first benefit that we're tackling. Want to thank Karen and Nevada PEP for all their partnership in over many years to get to this point, and we're excited to kind of share with this group what that process has looked like and what our path forward is, and to get your feedback on how to build it in a way that really works for our community. Our February meeting, the date and time are TBD, because I want to make sure that this Thursday evening spot works for the majority of our representatives. This is based on feedback you all gave, and I appreciate it. So we will just take one more moment to adjust before this gets set in stone. But we'll begin to really talk about our psychiatric residential treatment facilities as well as our specialty managed care plan. So a lot of work ahead. I'm really looking forward to doing this all together. And with that, we will turn to public comment. So definitely at this time, we will offer that opportunity for public comment. As a reminder, no action can be taken as a result of public comment period unless it's specifically included in the agenda, but we welcome feedback from those public members of our community on anything that we have discussed today. So Charles, we'll start with you.
Hi, Anne. Thank you. First of all, I want to really, thank everybody for all of the responses that have been given, because there's a lot of work here to do in Nevada. But when you were talking about data metrics that would be helpful, I think one of the data metrics that would be helpful is we do have a children's mobile crisis response team. And one of the data metrics that we have not been capturing has been around how many of those responses are happening for families and children and youth who have not previously been encountering the mental health system. This is obviously like a really important thing for the consortia and the policy boards to know and understand as we move forward with making recommendations. Because the families that I've worked for or worked with in the past when I was with Nevada PEP, many of them, this was their first introduction to mental health. They had no clue that this was coming or how to respond or what to do in response to all of that. And I put in chat earlier that one of the barriers is that families just don't know what they don't know. And if they don't know what to look for and there's no outreach done to inform them of what's available and what they could be accessing, that's really a problem. So I'll leave it there, but thank you, Anne.
Thank you. That's great feedback. And as we build a no wrong door system. We want to make sure we're both connecting those youth and families appropriately to care and tracking where we can try to intervene earlier and provide supports earlier. So thank you for that. James?
Oh, yes, thank you. I saw on the previous slide that you had mentioned an RFI for the specialized pediatric behavioral health plan. When does the division intend to release that RFI?
Yeah, thank you for noting that. We intend to release that after the holidays in the new year. So we may not have the full responses to share with the group. I think that was actually a leftover bullet from an earlier conversation. So thank you for that catch. We will cover it either in February or in future dates, but we look to release that in the new year. So thank you.
Great. Thank you.
Yeah. Kim?
Couldn't get off mute. Just really quickly on the barriers to the inpatient services and the residential services, one thing I wanted to flag is we really have a hard time sometimes getting kids admitted to programs, particularly if they have a variety of needs. Our dual diagnosis youth, youth who have intellectual and developmental disabilities in addition to their significant mental health, it's very hard sometimes to get them admitted into programs. And unfortunately, for some of our kiddos who have been in and out of care multiple times, they sort of end up on, for lack of a better phrase, like a no-fly list, where a lot of the acute hospitals don't want to accept them because of their behaviors. And we end up in situations where kids are stuck in emergency settings. We also had a situation about a year ago where a youth in detention who was highly acute, we could not get her admitted into a single acute hospital in Clark County. She ended up having to be driven by ambulance all the way up to Reno Behavioral Health. And that's just simply unacceptable as a way to get acute care for a youth in desperate need. And so figuring out a way to ensure access to acute care, despite the fact a child might have a history or significant behaviors, is hugely important for our kids in crisis. And then similarly, we run into those barriers in residential treatment when there's any other complication in addition to the mental health. So kids with mental health who also have diabetes and need a program where there's going to be nursing on staff to handle that, or kids who have a dual diagnosis with substance abuse. So not only do we have a shortage overall of the programs that we need, but having programs that will accept the full child. And this goes to, I think, part of the comments that Matt was making too about access to ABA within a regular treatment setting, those sort of things. So that's a huge issue that we see as a barrier for kids.
Thank you for sharing, Kim. Yes, I believe we will spend significant time in this working group talking about how to best serve our population of youth with dual diagnoses. They are a crucial part of this transformation, and we know that they have very distinct needs. And we need to think about how we're designing our system accordingly. So thank you for sharing that. I appreciate it. And Jonathan.
Yeah, thank you. I guess I'm wondering, I feel like this work has started because we know we're not doing a good job for our kids, but also because we have a case filed by the Department of Justice against Nevada. And we've been being told for over a year now that that settlement is like on the verge of being public. So right now at this point, we don't know any of the scope of that settlement. We don't know any of the teeth in the settlement to ensure that we are living up to our obligation. And so it's really hard to have this discussion about change when we don't know. We're relying and we're being told that this is being developed, but it's been, over 2 years now since that complaint was filed. And then I think a lot of times when I'm thinking about MCOs versus fee for service for our populations that we serve at, CAP and, Gwyneth works with, I think of how have we done with other populations that have transitioned into MCOs in the past, and do we have a track record of showing that that has gone well for those populations? So I'm thinking of the Medicaid expansion that brought in folks who are 138% of the poverty line, and do we have a track record of serving those folks well that tells us that, yeah, we can do this in this setting? And then I just want to learn more about why will MCOs be different? We all know we have not enough providers and everything we've talked about on this call. So why is that different in the new world we're creating? And I'm not there yet. Like, I don't understand that step.
So Jonathan, this is Stacy. To your first question, I can't speak to that DOJ agreement. It's confidential. So I think you know that. I will tell you what we're doing is in alignment with that, and we are moving forward regardless of that. The teeth here is that we are doing it. We don't need a court order to do the right thing. So I just want to start with that. We have funding for the first time ever too, that we haven't had in this state. So that also is driving a lot of this. That if we had, it wouldn't even matter right now if we had the agreement. If we didn't have any funding, I wouldn't be able to do anything. So that's number one. Number two, for the managed care plan, I hear you, but this is not your typical managed care plan. I've tried to say this a couple times. It's a specialty plan designed and focused on behavioral health needs for these children. Ohio Rise is doing this. They're nationwide, one of the best practices, and at least from our perspective in Medicaid, we're looking at modeling what they're doing. The piece on the fee-for-service side is we are not equipped as a state to manage every case. We cannot have enough case managers. I mean, I know the counties struggle with this, but if we expect that we're going to be able to deliver that type of care at the state level, I can promise you we're not going to be able to staff it. And so we've got to figure out a better way to do this. We're not looking at a fully risk-based model, and I'd like it if we could table this conversation to the day we do talk about managed care, because we are going to have a full presentation on that. And I think that's the opportunity where we can think about, we've got to do something different, Jonathan, because I can promise you fee-for-service is failing. And that's what we got now. And if we continue down this route, I can put all the money in the system and we're not going to see anything. So we've got to think about something different. And I get, maybe it's a hybrid, maybe it's a little bit of both, but we've got to think about something else to actually ensure that we're tracking quality, that we've got money on the table. Managed care plans have money to put on the table that I don't have as a Medicaid program. And so those are the kind of things that I want to use to drive into doing better. So I would appreciate, I think when Anne has the managed care conversation, if we could table some of that for then, and then maybe Anne, we should do that right after the RFI so we can make sure that that's informed and people have what they need to actually respond to that RFI. So I'll stop there. Thank you.
Absolutely. Yes, we do plan to have a dedicated conversation to the design of that plan. So look forward to having that early in the new year. So thank you, Stacy, and thank you, Jonathan, for your comments. I appreciate you all for staying 6 minutes over on late on a Thursday evening. So thank you all for your time. If you have any questions or feedback for our team, you can reach us here at our Children's BH email address. We thank you for your feedback and your time with us today, and we really appreciate it. So take care.
Thank you.